Chapter 1 relates to using the medical record as a source document for coding. The entire medical record should be reviewed. You should start by reading the discharge summary, since this is a synopsis of the patient's hospital stay, including the reason for admission, significant diagnostic findings, treatments given, and the patient's course in the hospital, the follow-up plan, and a final diagnostic statement. Then read the history and physical examination and any consultation reports. Review the laboratory, radiology, cardiovascular, and EKG reports to identify an abnormal value and determine if the physician is treating the patient based on these findings. Although remember, you cannot code based on abnormal findings solely. There must be a correlating diagnosis made by the physician. But review of these reports may prompt you to query the physician for a diagnosis. These other reports may help contain information for you to code to the highest level of specificity. For example, lab reports for the organism responsible for the infection, and the X-ray or an operative report for the specific bone fractured. Again though, remember the physician should indicate the confirmation by documentation within the medical record. You should also review the patient's progress notes, medication administration record, and the nurse's notes. You may be able to find the stage of a pressure ulcer or a body mass index in these other notes, which you can use to code since the condition of pressure ulcer and obesity has already been made by the physician. This additional information may be documented by clinical personnel. Facilities may also have their own internal coding guidelines to help provide assistance when determining when a physician query is appropriate. For example, if the test findings are outside the normal range and the physician has ordered other tests to evaluate the condition or prescribe treatment, the internal coding guidelines may not interpret abnormal findings when replacing physician documentation or physician query. If it appears that another diagnosis should be designated as principal diagnosis, or if the conditions not listed should be reported, follow the healthcare facility's procedures for obtaining a corrected diagnostic statement. The official coding guidelines and reporting use identify the term provider to mean a physician or a qualified healthcare practitioner who is legally accountable for establishing the patient's diagnosis. Code assignment may be based on the documentation of other physicians involved in the care or treatment of the patient, so long as there is no conflicting information from the attending physician. These other physicians may include consultants, residents, and anesthesiologists. If the documentation does differ from the attending physician, the attending physician should be queried for clarification because he or she is ultimately responsible for the final diagnosis. Pathological or radiological findings for inpatient coding, if the attending physician does not confirm the pathology or radiology reports, query him or her regarding the clinical significance of these findings and request that appropriate documentation be provided. When coding outpatient lab, pathology, and radiology encounters in a hospital-based as well as standalone facilities, it is appropriate to sign codes on the basis of the written interpretation of the radiologist or pathologist. Incidental findings on radiology reports are considered inappropriate to assign or report an incidental finding, especially when the finding is unrelated to the sign, symptom, or condition that necessitated the performance of the test for the patient, such as being seen in the emergency room or being worked up. The ED physician would need to clarify that the finding was clinically significant and related to the visit in order for it to be coded. In some institutions, there are mid-level providers, such as nurse practitioners and physician assistants, who are involved in the care of the patient and who document diagnoses in the health record. It is appropriate to code assignments on the documentation of mid-level providers if they are considered legally accountable for establishing a diagnosis within the regulations governing the provider and the facility. when dealing with documentation from physicians and mid-level providers. It is not appropriate to code a diagnosis on the basis of an up or down arrow. For example, an up arrow in front of cholesterol, meaning increased cholesterol or hypercholesterol, or a down arrow in front of potassium. The up and down arrows can have variable interpretations and do not necessarily mean an abnormality. The provider should be queried for the meanings of the arrows and request documentation and be requested to document the clarification. This advice applies to both inpatient and outpatient records. Documentation by non-physician providers. It may be appropriate to assign a procedure code based on documentation by a non-physician professional who provided the service. These apply only to procedural coding when there is documentation to substantiate the code. It does not apply to diagnosis coding. An example would be an infusion carried out by nurses or therapies provided by physical therapists, respiratory therapists, or occupational therapists. In the field for patient's reason for visit, only one diagnosis can be reported in this field on electronic claims. The paper claim UB04 has been expanded to allow for 3 codes. And the last item in here is the present on admission indicator, and we're going to refer you to Appendix I of our coding book, which is the coding guideline for present on admission. These apply to diagnosis codes for claims involving inpatient admissions to general acute care hospitals or other facilities.